going from narrow to the continuum?
Yeah.
Okay, great question. In a nutshell, if you think about a set of services, let's look at something fairly straightforward and simple. We're talking about an orthopedic procedure, hip replacement, knee replacement, surgical intervention, typically not emergent. The event has a defined beginning, it has a middle, and it has an end. If you look beyond the very specific surgical episode, which is how a lot of the cost today is calculated, and you stretch that out, you understand that there are arthritic conditions, there are things that happen before the decision to come to surgery takes place. There's a decision criteria that needs to be walked through. There's also the getting ready for the surgery, there's the rehab on the back end. So as you extend that, using that as one example, and you think about the quality, the decision points that have to be made, and the evidence base that's required, looking at what we know about success in treating these kinds of difficulties, you begin to understand that. And well, our bias is that we want to be able to do this on a bundled price basis. And so that as a consumer, I know I'm going to have an all-in price that's going to be X, and it's going to include all of these services that are surgical or not. They're going to get me ready for an optimal outcome in surgery. The surgical experience, I know what that's going to look like, and on the back end, we know what the rehab is, and I can expect to return to normal activity. That's one example. We're also doing this work in the area of cancer care. We're doing the same kind of work in the treatment of diabetes, which is less specific over a period of time, in heart disease and a whole variety of other things. And then ultimately, you'll be able to roll that up. Ultimately is not a flip of the light switch, but ultimately be able to roll that up into more broad population management. But that's how you get there.
How is that paid for if you bundle it all together? Who gets the pieces? Because right now it's okay. The surgeon says, "I want to have this," and you're going to get billed by your hospital. You're going to get billed by the doctor. You're going to be billed by the rehab. Everybody's billing separately. Now you bundle it all together. Who's going to pay the fees, and who's going to decide how that bundle price is done?
It's a. Do you want me to respond to that?
Go ahead.
Michael has a great response to this question. And so the short story is you need to understand what your underlying cost structure is across that entire continuous starting point. There is a lot of analysis that has to happen because there's an incredible amount of variation in both cost and quality, even when we're talking about something as relatively straightforward as an orthopedic implant. Okay, when we're talking about cancer care, it gets a lot more complicated, even when we're looking at that orthopedic example. And so what you need to be doing is understanding what your historical costs are across that continuum. You need to understand what best practices are related to the combination of cost and quality. Because I'm very concerned about what those outcomes are. And there may be certain physicians, as an example, who are able to do things within surgical experience or getting patients ready, where their costs may be higher on the front end, lower on the surgical piece, and they have shorter recovery times on the back end. There's something that they're doing that leads to better outcomes for those patients, controlling for patient complexity and comorbidities and so forth. So what we're talking about is understanding the underlying costs across that continuum, historically and going forward, assuming we're all going to be standardizing on best practices going forward. What can we expect that to be? And engaging, aligning the various players so that they understand what their contribution is and they sign up basically for doing their piece, for their outcomes being defined, and that's how you get the whole thing together. It is not easy to do, but it is doable, and it's a lot less complicated ultimately than the system that we have in place today.
As you talk about understanding the cost of the continuum of care and getting the best value based upon quality, I also heard you talk about relying on best practices. would not be one of your unintended costs of this system, which I actually see now, when you talk about best practices, is new technology, new practices, and people refusing to pay for that when you don't know what the long term of that is. So wouldn't the unintended consequence be stifling of entrepreneurial, new technology, et cetera?
Well, I'd speak to that. In situations where we're working on bundled pricing, just like really in any other kind of business, you need to budget on a forward-looking basis for the introduction of new technology. So every organization puts aside money for new IT systems, new machinery, because they know that they're going to either need to replace things or they're going to be new developments that come along that they need in order to stay competitive. That's factored into the budget, and that's factored into the price. Obviously, there's a lot of experience required in order to understand how to do that on a go-forward basis, but that is how we would expect to see bundled pricing work, where you do anticipate what the introduction of new technology will cost, and you factor that into today's price so that you can have that money to spend when you need to. Does that get it, what you're talking about?
If I can add something to that. The other thing is in other industries, when new technology comes in, it tends to ultimately decrease the ultimate cost of other things that are in place. In every other industry, new technology coming in has, in fact, brought about greater productivity and gains elsewhere. I think that if you look back at how long it took for people to recover from open heart years ago, where there's new technology, people are in and out in a matter of a couple of days, where it used to be several weeks. And so over time, I think this begins to wash well. And real advances in technology that has meaningful clinical and economic value as opposed to just new widgets that don't really bring value to the system, I think are ultimately going to reduce total cost